No, this is the second lecture for heart examination for skill lab for fourth year, and we'll talk today about auscultation. Of course, we use a stethoscope in auscultation. The chest piece of a stethoscope should have two parts, diaphragm and bell or cone. The diaphragm is the bigger one, and it is used to hear most of the sounds, which we call them high-pitched or medium to high-pitched sounds. And murmurs, like first heart sound, second heart sound, like aortic stenosis, mitral regurg, sorry, this is a mistake here, and other heart sounds and murmurs. It is used in all areas, and you should use it. The second part, which is the bell or the cone, it is sensitive for the low pitched sounds, the faint sounds, which are, let's say that they are two sounds, third and fourth sounds, and the two murmurs, which are mitral stenosis and tricuspid stenosis. So all these four things are used, we use the bell or the cone. And if you notice, mitral stenosis, tricuspid stenosis will be heard at the apex of the heart and in the parasternal area. So usually when we are hearing the apex of the heart and the parasternal area, we have to shift between cone. We hear once with the cone and once with the diaphragm. But when we go up to the base of the heart, the pulmonary area, aortic area, there is no need to change to the cone and hear with it, because all the sounds and murmurs there are high-pitched or medium to high-pitched. Some of the stethoscopes have one side only, which is double. I mean, like when you put it with a light pressure, it is a diaphragm, but when you press it more, it becomes a cone. But this is, although it is a cardiology approved stethoscope, but it is not recommended to use it in the undergraduate exams, because we are giving you marks regarding changing between, because we want to see that you are changing between the cone and the diaphragm. The most important thing, and I hope all will know this by heart, is the auscultatory areas. In the previous slide, we talked about the areas of inspection and palpation, which were 4 areas. Here, we are talking about the auscultatory areas. They are 5 areas. 3 of them are nearly similar to the palpatory areas. So let's talk about them. The first area is the apex. This we call it the mitral area. In the palpation slides, we called it left ventricular area, but for the sake of the valves, this is the mitral area. Left fifth intercostal space, mid clavicular line. So this mitral area, when there is mitral stenosis or mitral regurg, we hear it on this area. Okay. Up here, we have same like during palpation, we have aortic area and pulmonary area. Pulmonary area is on the left side, left second space, left second intercostal space, parasternal. So pulmonary stenosis, pulmonary regurg are heard on this area. And the aortic area, or we call it the first aortic area, it is in the right second intercostal space, parasternal. Okay, so we have aortic area, right second, we have pulmonary area, left second, and we have the apex. What is remaining is here. When we were talking about the palpation, this area was called RV area, right ventricular area, 3, 4, 5 intercostal spaces. But here we will divide them into second aortic area, which is designated here as 3. This is, we call it Erb's point, or second aortic area. This is very important. It is the left third intercostal space, parasternal, and here we can hear the aortic regurg. It is very important because it is specific for aortic regurg, and there is a specific position the patient has to do in order to hear the aortic regurg. So in the area 1 here, we hear only aortic stenosis, and in the second aortic area, we hear aortic regurg. Then for fourth intercostal space, or fourth and fifth intercostal space, this is the tricuspid area on the left side. So in summary, we have first aortic area, right second intercostal space. We have pulmonary, left second intercostal space. We have second aortic area, left third intercostal space for aortic regurg. We have tricuspid area, left fourth and fifth intercostal space, and we have the mitral area, which is in the apex. This is very, very important to know. Sometimes in the exams, clinical exams, we just ask about these areas and we find that people are not answering correctly. You have to know these areas. Again, my busiest slide. So in summary, when you are asked to auscultate the heart, first, of course, you can inspect quickly if there is any scar. Why we inspect especially for scar? Because if you find median sternotomy scar, which we talked about last time, for the exams and for our patients, mostly the chronic patients, mostly there will be a click of prosthetic of mechanical valve. So you expect to hear a mechanical click if there is a scar. Okay. And you can also, I know you are asked to auscultate, but quickly you can have a look to find that if you can see the apex beating or not, because if you can find by inspection or quick palpation the apex, it's better, so you can put the stethoscope exactly on the apex. Then you have, as you like, if you want to start from the base of the heart, like aorta, pulmonary, second aorta, tricuspid, mitral, from up to down, or from down to up. Actually, for me, I prefer from down to up. You start with the apex, then you go to tricuspid, then second aortic, first pulmonary, and first aortic area. It's very important that in the apex, you have to auscultate with the diaphragm and then with the cone. Okay? Okay, so what are we looking for? Two things. Heart sounds and heart and murmurs. Sounds and murmurs. So first, you will concentrate on the heart sounds. You put the stethoscope on the apex with the diaphragm and concentrate about the heart sounds like lub, dub, lub, dub. So you will find two sounds. Everyone should have two sounds, lub, dub, first and second heart sounds. Okay, how can we know which one is the first sound and which one is the second sound? The best way is to synchronize or to palpate the carotid artery while you are hearing the heart. And this is a very important step, and you will find that you will get marks if you do it, and you will lose marks if you don't do it. So you have to put the diaphragm on the apex, concentrate on, to hear the sounds, concentrate on the sounds, not the murmurs. The murmurs are like like abnormal things, but the sounds are S1, S2, lub, dub, lub, dub. So you concentrate on the sounds and you put your left, by the left hand, you have to palpate the carotid. Okay, while you are auscultating, you have to palpate the carotid. And then you see which sound is coming with carotid pulse, not the radial pulse, by the way. So while you are feeling the carotid pulse with your left hand, you are concentrating in hearing the heart sounds to see which sound is coming with the carotid pulse. This is the first heart sound, S1. The other sound is S2. And any murmurs you can hear after this S1, it will be also nearly with the carotid pulse. It is a systolic murmur. Okay, so the sound and the murmur which are synchronized with the carotid impulse, these are systolic phenomena. Okay, so you concentrate on that. You try to see if this first heart sound is very high, is very low, or it is metallic. It has a metallic sound, a metallic click. Okay, and then you concentrate on the second sound. It is better to hear the second sound. Actually, the second sound can be heard on all the heart, but it is better, both sounds, but it is better to comment on the second sound up in the base. Okay, so you take the stethoscope up and comment on the second sound, which will be the sound not with the carotid impulse, and you have to compare between the aortic area and the pulmonary area. We will talk about this later on. Okay, then the second step is to comment on the murmurs if there is murmur. So you return back again to the apex, check with the diaphragm if there is murmur or not. If you hear a murmur, you can again compare it using the carotid to see if it is systolic murmur or diastolic murmur. And you can go with the stethoscope to the axilla to see if this murmur is radiating to the axilla or not. Okay. And then you have to change to the cone and check again if there is any diastolic murmur for mitral stenosis. So if you find the diastolic murmur on the apex, it may be mitral stenosis. If you did not hear any systolic murmur or any diastolic murmur, you have to put the patient on the left lateral position, and he can make some exercise with his legs in order to see if there is to hear any murmur. Because by this, mitral stenosis can be slightly better heard. And you turn back the patient to his normal position. And then after the mitral area, you go to the tricuspid area. You check for any murmur, tricuspid stenosis or tricuspid regurg. And then you go up for the aortic area, second aortic area, pulmonary area, and the first aortic area. Before you finish, you have to be sure that there are two positions you did for the patient. One of them, which I said about, is to put the patient on the left side while you are hearing the apex with the cone in order to try to pick up mitral stenosis. Okay. The second position is another important one. You put the stethoscope on the Erb's point, which is the second aortic area, left third space. Then, if you don't hear anything, you let the patient sit, lean forward, and hold his breath at expiration. Okay, these are very important 3 steps. So the patient has to sit, lean forward, and take inspiration, expiration, then hold his breath in expiration. Where is your stethoscope? In the second aortic area, which is the third left space, and you are trying to hear a murmur for aortic regurg. Okay. So in these figures, you can see this is the position for aortic regurg. This patient is sitting, he leaning forward, stops his breathing after expiration, and you are putting the stethoscope with the diaphragm on the third space on the left side. This position is the position for mitral stenosis. The patient is on his left side. Usually he do some exercise with his legs, so he can be slightly tachycardic. It will make the murmur better heard. And he is using the cone, not the diaphragm, trying to hear mitral stenosis. The heart sounds, you will find another video talking in more details about the heart sounds. In general, the heart sounds, we have 4 heart sounds. S1, first heart sound, S2, S3, S4. S1 is a normal sound, should be heard in all people, and it is due to closure of the atrioventricular valves, mitral and tricuspid. The best way, it's heard on all the heart, but the best place to hear the first sound should be in the apex of the heart. Second heart sound, it's again a normal sound. It's by closure of the semilunar valves, aorta and pulmonary. Again, it's also a high-pitched sound is heard with the diaphragm, and it is heard on all the precordium, but better to be heard or commented on the base of the heart, aorta and the pulmonary area. Third heart sound, sometimes it is normal in young people or in thin people, but it can be also pathological. We will talk about this. It's a diastolic sound, and we'll talk about this later on. Fourth heart sound is usually not normal. If you can appreciate fourth heart sound, usually there is some pathology occurring. It is also a diastolic sound. We will talk about the splitting of heart sound separately when we are talking about second heart sound. Okay, what about the murmurs? Murmur is it's not it is a turbulence. It is an audible sound due to turbulent flow. Normally, the blood is flowing through the heart, through the valves, through the heart chambers without causing any turbulence and without causing any sound, any murmurs. But when something happens causing turbulence, like stenosis of a valve, regurg, presence of ASD, VSD, even in some cases of very fast fast or increase overload of the heart, like in cases of anemia or thyrotoxicosis, some murmurs may happen. The main causes of murmurs are stenosis of valves, regurg of valves, and the presence of connections between chambers like atrial septal defects or ventricular septal defects. When we talk about the murmur, we have to comment on several properties. What is the timing of the murmur? Shape, intensity, pitch, quality, location, radiation, and response to dynamic maneuvers. Timing means I will make a new one for, and you will find a new video for the whole more details about the murmurs. But in general, murmurs by timing either systolic or diastolic. Systolic murmurs means they come between first sound and second sound. And how we can know? We can know by comparing with the carotid. If the murmur is present during the carotid impulse, this means that it is a systolic murmur. And systolic murmurs can be further divided into according to their shape. Either like this, meaning like the murmur is getting up, start low, becomes maximum, then returns back to be faint. We call this crescendo, decrescendo, okay? Or they call it diamond-shaped murmur. Like the murmur starts faint, becomes high, strong, then becomes faint again during the systole. Another shape of the murmur is this one. This is pansystolic murmur or holosystolic murmur, meaning that it is nearly in the same intensity all over the systole. And there is a third one which starts low and becomes strong and finish like this. We call it late systolic murmur. So we have pansystolic, mid-systolic, and late systolic. Diastolic murmurs, we have murmur which is, of course, diastolic murmur will start after second heart sound and away from the carotid impulse. So we have early diastolic murmur which usually starts strong and become faint later on. So it is decrescendo. And we have another one which is mid-diastolic murmur. Again, it is decrescendo, but it does not start with second heart sound. There is some space, then it starts. And there is the opposite one, which is the late diastolic murmur, starts slow, like here, and becomes maximum by reaching the first heart sound. Okay, so these are generally systolic murmurs and diastolic murmurs, and don't forget that patent ductus arteriosus produces continuous murmur. When we talk about the intensity of the murmur, this means that what if the murmur is very strong or not strong? How can we speak the same language? I mean, you tell me that this is strong, or loud, I'm telling you, no, it's not loud. So some people make some strange grading of the murmur. Grade 1 means the murmur is very faint and is heard very difficult to hear it. Grade 2, the murmur is heard, but it is very quiet, and again, it's difficult to hear, but when you put the stethoscope, you are hearing it. Grade 3 is a moderate murmur, which is very easy to be heard. Usually, most of the murmurs we can hear are usually around this grade. Starting from grade 4, the murmur should be accompanied by thrill. We talked about thrill last time. Okay, so if you want to say that this murmur is grade 4 in the exam, you have to be sure that you already felt a thrill on the murmur. Okay, so if you are allowed to do palpation, you have to find the thrill, and you found a thrill, so there is murmur in this area, and this murmur is at least grade 4. And similarly, if you wanted to say that the murmur you are hearing is grade 4, you have to be sure that you already did a thrill, you already palpated a thrill for it. So starting from grade 4, the murmur is loud and the thrill is palpable. Grade 5, very strange, but the murmur is very loud, thrill is palpable, and even the murmur can be heard when you are stethoscope is partially off the chest. I don't know how we are doing that, but this is what is written in the books. And finally, grade 6 is very loud murmur, containing a and accompanied by a thrill, and even if you just removed the stethoscope from the chest, I mean the stethoscope is not even touching the chest, but still you can hear the murmur in your ears. Okay, in most cases the murmurs are between grade 3, grade 4, but in order to say grade 4 you have to be sure that you already palpated a thread. Next, in following slides, we will talk about different lesions and what is the murmur characters in each patient, in each systolic and diastolic. So, and please remember that in order to practice, in order to master auscultation, you have to practice. So you have to hear normal persons first, your friend, your brother, your sister. You try to hear normal persons first to be sure that you are, you are used to know the normal intensity of sounds, and then you can check the mannequins also. You will find special sessions on the mannequins we have, and then you can hear also from the internet. You can find YouTube channels and other sites which can show which have recordings of heart sounds and murmurs. And during the examining the patient, if the room is quiet and you are following the steps, you can hear well the murmur. The first step, as I said, you concentrate on the sounds to know which is the first sound and which is the second sound, comparing with the carotid. And after you are sure with the sounds, you can comment on the murmurs between the sounds. Okay, so please follow the next videos in order to know more details about the heart sounds and heart murmurs. Thank you.